All right, hello, and welcome to our contraception episode. Today we're going to be talking about the different ways that you can prevent pregnancy in a woman. And there are lots of different ways you can do this, and we'll be going through all of them, well, or at least the ones that I've come across. Contraception can be through the use of medications or some medical devices or behaviors, and so there are lots of different options, and the great thing about this is that it can be tailored based on a person's needs and values, and also their requirement for having future children and different risk factors, etc. All right, so we're going to delve right into it. We're going to start with hormonal forms of contraception. So, hormonal forms of contraception rely on kind of mimicking what it would be like if the body had already ovulated. So you want to trick the body into thinking that you've already ovulated, you've got a follicle or an oocyte that's ready to go, and a little corpus luteum, and that therefore we're going to mimic the production of certain hormones that would normally be produced. So these hormones specifically are estrogen and progesterone, and these are the main hormones that are used in hormonal contraception. So starting with the role of estrogen, which is usually produced by the maturing follicle, estrogen has a role in stabilizing the endometrium, so it decreases abnormal uterine bleeding, and it also reduces the maturation of other follicles. On the other hand, progesterone, which is usually produced by the corpus luteum, suppresses the production of luteinizing hormone from the pituitary gland, which in turn prevents ovulation. And it also thins the endometrium, which makes it inhospitable to implantation by any embryos. The last thing that progesterone does, very importantly, is that it thickens this cervical mucus plug, which forms a physical barrier against sperm. Okay. I'm going crazy. So now talking about the adverse effects of each of these hormones. So obviously, these hormones are ultimately systemic, and they play a role in our own body systems. So they have quite widespread effects. And for estrogen, these include irregular bleeding and increased acne, as well as the increased clotting risk. So for estrogens, you might have heard that people who are, for example, on the pill have increased risk of like venous thromboembolisms, which are like deep vein thromboses. Other cardiovascular events such as stroke, hypertension, myocardial infarction, and estrogens are also contraindicated in patients with advanced liver disease because they can cause hepatocellular adenomas. Now, progesterones can cause a different array of things. So they can cause irregular bleeding, dizziness, follicular cysts, and in one particular form of progesterone, which is an injectable called DMPA, it can cause a delayed return to fertility. Now, both progesterone and estrogen have some side effects in common. So these include headaches, breast tenderness, mood changes, as well as nausea and gastroesophageal reflux. Now, starting off with the most heard of form of contraception, this is the combined oral contraceptive pill. And in this pink box, I've kind of noted down all the combined hormonal contraceptives. So these all contain estrogen and progesterone, so a mix of these two, and hence you can imagine the adverse effects would be a constellation of these. Now, the way that the pill works is that you have a bunch of pills that all contain estrogen and progesterone, all in different forms. So you might get estrogen in the form of ethinylestradiol, which is a synthetic estrogen, or you might get estradiol, which is bioidentical. And then with your progestrogens, you could get levonorgestrel or desogestrel, for example. And kind of different pill brands have different combinations and different strengths of each of these. And high dose pills contain anything more than 50 micrograms of estrogen. So 50 micrograms is high dose. Ew, that was terrible handwriting. Okay. Now, the pros of the pill is that it can be used for reversible contraception. And it also allows you to have regular bleeding, because what happens is that you get a certain number of sugar pills where your uterus sheds its lining because it's not receiving that estrogen and progesterone. So what happens is you get a withdrawal bleed, and you can predict these bleeds. You know that they will happen when you're on your sugar pills. Another great thing is that if you really wanted to, you can actually use the effective pills back to back, so not take your sugar pills, and that means you can completely skip your periods altogether, although it does mean that you might experience some breakthrough bleeding. Another pro of the pill is that it's actually really effective in reducing pelvic inflammatory disease and ovarian cysts. It also reduces your risk of ovarian and endometrial cancer, and hence it is also used to treat things like polycystic ovarian syndrome, endometriosis, and hyperandrogenism. The cons of the pill are kind of those ones that are kind of covered by estrogen. So it does increase your risk of clots, so venous thromboembolisms and strokes. And, interesting to note, it does increase your rate or risk of cervical or breast cancer. So hence, having breast cancer is a contraindication to receiving estrogenic or combined hormonal contraception. Other forms of combined hormonal contraception include a patch, which is used once a week for 3 weeks, and the Nuva ring, which is a vaginal ring containing ethinyl, estradiol, and etongestrel, which is estrogen and progesterone, and this is put in the vagina for 3 weeks. And I've also put here for each of these the efficacy against unwanted pregnancies. So if I write perfect use, that means that in an ideal setting, in a clinical setting with perfect compliance, so in the case of the oral contraceptive pill, they're taking their pill every single day at the same time, it would be 99.7% effective. Or for the patch, it would be 99.7%, same with the Nuva ring. However, in real life, the typical user will experience 92% efficacy for the pill and 91% efficacy for the patch and Nuva ring. Now, moving on to the progesterone-only forms of contraception, these were really great in people who have certain contraindications for using estrogen. So they might have a really high risk of thromboembolism, or they might have a hepatocellular carcinoma, or they might have had previous breast cancer or current breast cancer. And so if they wanted some kind of contraception, you would point them towards a progesterone-only contraception. So starting off with the most effective and safest and most commonly used progesterone-only contraception is the mirena, aka a progestogen-releasing intrauterine device. So what this does is it sits inside the uterus, and if you can imagine, we have a little mirena. It's kind of sitting here, it's inserted, and it can be left there for up to 5 years, which is really, really great because then you don't get any issues with user compliance. The cons of the IUD, the mirena IUD, is that you're more likely to get irregular spotting and amenorrhea, which is actually sometimes a really great thing. So for people who experience really heavy menstruation, the mirena is a really, really effective way to control that bleeding. Some people will get reduced periods, and some people won't get periods at all. Another con of the mirena is that you do have the risk of it being kind of risk of expulsion from the uterus, especially in multiparous women with softer cervixes. And also during the insertion of the mirena, because you're entering it into the tissue of the uterus, and it is a invasive procedure in that sense, you can perforate the musculature of the uterus. Another con is that if you do happen to fall pregnant during with a mirena in, it does increase your risk of ectopic pregnancy. However, the IUD, I actually haven't written here, but the IUD does have a 99.9% efficacy. So it's very unlikely that you're going to fall pregnant with the mirena. Now, another form of progesterone-only contraception is the mini pill, or the progesterone-only pill. Sorry, this is kind of an inaccurate photo, because the progesterone-only pill doesn't come with these sugar molecules. You only get progesterone. And so the reason that you might use this is if you have a breastfeeding patient, and because progesterone doesn't affect breastfeeding, whereas estrogen does. And other areas where estrogen is contraindicated, which I've mentioned before. Some cons is that the progesterone-only pill very specifically has to be taken at the same time every day. And if you don't take it, it will lose its efficacy. As opposed to the combined oral contraceptive pill, the COCP, or if you don't take it for a day, as long as you take it the next day, even if it means doubling up your pills, you will usually still be covered. So with the mini pill, what can happen is you get a higher failure rate due to strict adherence requirements, and because you don't have that set bleeding time with sugar pills, your bleeding can be more unpredictable. Now, there are two more other forms of progesterone-only hormonal contraceptives, and these include progesterone injections and something called the implanton, or the rod. So, starting with progesterone injections, you might have heard of this as Depo-Provera, and these are very effective, as you can see here. And the pros include, those pros of why estrogen might not be necessary or appropriate, whilst cons include irregular bleeding, increased appetite. It's not easily reversible, simply because you've had this injection and it does last a little bit of time. Usually it might be around 8 months until ovulation recommences. And another thing is that because of the extra kind of hypoestrogenic effects, you might get reduced bone density and hence a tendency towards osteopenia or osteoporosis. Now with the implanton, this is also very effective. It's kind of inserted into a person's arm. Imagine that being someone's arm. And it slowly releases progestogen. That's weird. That's supposed to be there. This is 99% effective. It releases 60 micrograms of etonogestrel per day, and this slowly titrates down to 30 micrograms. And this lasts around 3 years. However, the main con of the implanton is that a lot of people will complain about intermenstrual bleeding, constant spotting. That isn't really cyclical at all. So it's not as popular as the mirena for that reason. Now moving on to barrier methods of contraception. Actually, I'll just quickly mention this little guy here. So the copper IUD is also another choice for intrauterine device. And the way that this works is that you have your plastic intrauterine device and it's covered in copper, which is naturally inflammatory and thus creates a really, really hostile uterine environment, not only for the for implantation, but also for any sperm. So this is the longest lasting non-hormonal contraception. actually longest lasting contraception in general. And it can also be used as emergency contraception. So after intercourse, if it's inserted into the uterus, it is very effective at preventing the continuation of a pregnancy. The cons of a copper IUD is that it can cause prolonged and heavy menstrual bleeding, which kind of sucks. So yeah, just take it with a grain of salt. Take all of these with a grain of salt. But as you can see, they're very, very personalizable in terms of how many choices there are. Now, moving on to the most well-known form of contraception, these are the barrier methods. So physical barriers between the sperm and the womb that kind of have various levels of efficacy based on how well educated and the patient is and the technique used to put these on. So starting off with condoms, we have the male condom, which goes over the penis, and it has a 98% efficacy in perfect use and 85% efficacy in typical use. So it's supposed to be placed onto the penis with the little nipple pinched and then rolled down over the erect penis. Then you have the female condom, which is an internal condom. It's placed inside the vaginal canal. So this part is an open ring that is placed outside of the vaginal vault, and this ring is closed and is placed over the cervix. So this fills the entire vaginal canal. This has a 95% rate of efficacy in perfect use, 75% in typical use, and is generally not really commonly used in general. Then we also have things like a diaphragm, which is a large kind of plastic item which is placed internally, so it's inserted over the cervix in the posterior and anterior fornices, and it's also coated in a spermicide gel, and it needs to be left in for 6 hours after intercourse in order for the spermicidal gel to do its thing, and also so that the sperm can be naturally obliterated in the hostile vaginal environment. And then you also have a cervical cap, which is smaller. It just goes over the cervix. It doesn't really stretch as much, cover as much surface area, and it's way more effective in nulliparous than parous cervixes. So people who've had multiple children, even in perfect use of the cervical cap, you only get 74% efficacy versus 91% in someone who hasn't had children before. Now, moving on to some behavioral methods of contraception. These are very interesting. I was reading about them. So you have the main one, which you may have heard about, is the calendar method. And so by tracking your periods and knowing exactly how long your cycle is, you can kind of determine which days you are fertile or which days are around your ovulation period. So based on your tracking, you should not have any unprotected sex between days 8 to 19 of your cycle. And this is not reliable in women who record 2 cycles outside of the range of 26 to 32 days in any single year. So you have to have really regular cycles in order for this to work. This is 95% effective in perfect use. However, in real life, prone to human error, we might not be so good at tracking our own cycles, and so the efficacy in real life drops to 88%. Then there's also the cervical mucus method, and this is based on the idea that before ovulation, your mucus from your cervix is thin, stretchy, and slippery, whereas after your ovulation, it kind of goes thicker and stickier, and so you're not supposed to have intercourse during these changes in your cervical mucus, and continue to not have intercourse until 4 days after peak cervical mucus thickness. This is quite effective, theoretically, not as effective in real life. Then lastly, we also have the basal body temperature method. So this is based on the idea that your basal body temperature increases by 0.2 to 0.5 degrees Celsius during ovulation and for the days after. And so you're supposed to measure your temperature every time you wake up and chart this, and not have any intercourse until more than 3 days after the temperature increase. So that's supposed to tell you when you're most fertile. And then finally we'll conclude with looking at the surgical methods of contraception. So these are usually used when a person does not intend on having a family anymore. So starting off with the female options, we have tubal ligation, and this occurs in a few different forms. So this can be done through diathermy, which is kind of your fire rod where you zap it, and it coagulates your blood vessels and causes fibrosis. You can also clip it, put a ring, or ligate. And this is 80% effective. Which is not very effective in my opinion, but yeah, a lot of people get it done after they have their final cesarean. And then we have, for males, a vasectomy. This is actually very, very effective and is supposedly reversible. So 98.8% of the time, it prevents unwanted pregnancies. But this is only if azoospermia is confirmed. So a male must send a sample of ejaculate to pathology to check that they are not producing any sperm afterwards, because if it was unsuccessful, or if, say, in many years' time, the vas deferens actually kind of rejoined, it can then cause unwanted pregnancies. But yeah, I think there has been a lot of talk about vasectomies being reversible, which they are, but in general, they should only really be done in men who don't intend on having children anytime soon. So that is it. That is contraception. There is so much to know, and I wish that this was used to educate younger girls, younger females of high school age, because it's really important, and I feel like it's very much not talked about. So I hope you learned something. I definitely did. And this is Val signing out. Goodbye.